Thank you, Mamita. I'm very happy that Karina decided to discuss this very important subject is monitoring. Control of diabetes is based on basically three principles. One is a right kind of treatment, which may need drugs or insulin or proper dietary interventions, lifestyle management, physical exercise, and to see whether these therapies are working well in a given patient. There is only one way to find out, to see what's happening to his blood sugar. Simple. Diabetes is disease of blood sugar. You start treating a patient with a blood sugar is more than 140 fasting and post-lunch more than 200. Then to see whether your treatment is effective or doing something good or something bad. That means while treating him, you're overdoing it. And he's going into what is known as hypoglycemia, which is a bigger enemy. Therefore, monitoring is an integral part of a therapy for diabetes. I always say that taking insulin and monitoring is like a maifal. In a maifal, the singer is important, but uska sathi, yani ki tawalji, peti, that is also equally important. So, monitoring is like accompanying instruments to insulin therapy. And therefore, without good monitoring system, there is no point in treating patient aggressively. Now, what has happened formally, when the people would come to a doctor, they will come with an elevated blood sugar. And there was a gold standard, fasting sugar more than 140, post-lunch more than 200, and HbA1c more than 8. So there are three angles to the triangle. And you would aim at bringing down all three angles. So you treat fasting first, then postprandial blood sugar also has to be brought down because that's a very big risk factor. And the HbA1c, which is overall control for 3 months, that also has to be brought below a magic figure of 6.5. So while doing that, there are certain manipulations. When you put a patient on a tablet, either the tablet can be short-acting, long-acting, or a tablet can be dual control or a triple control. You can give 5 or 6 tablets with the ultimate objective that the blood sugar comes down to the target level. Now, when you're doing this, you're running a risk of the blood sugar coming below 60, and that can happen during sleep. What we call it nocturnal hypoglycemia, which is very risky, which can precipitate cardiac abnormalities, cardiac arrest, sudden death. And therefore, if you want to avoid the hypoglycemia, you have to know how much is the time action profile of your insulin or tablets, and whether you need a fine tuning of your treatment. So you try to live in the specific zone of safety and what we call it target blood sugars. So formally people would go to a lab. They go after 15 days, check a fasting sugar, then take a good lunch. 2 hours after that, they will go to the lab again and get a printed report from the laboratory. Now that has become a bit cumbersome when you want to have the blood sugar reports every week. So that needs to be understood, that you can't go to a lab every week, or you can't call a technician home every week. It's costly, it's troublesome. So there are now lot of new gadgets which have come. And the simplest gadget is a glucometer. With a glucometer, with the help of strips, you can check your random sugar, you can check your fasting sugar, you can check your blood sugar 1 hour after lunch, you can do it after 2 hours after lunch. You can take a midnight sugar if there is a danger of midnight hypoglycemia. Then not only that, you can check your sugar after taking your favorite dishes. A lot of people say, doctor, when I take grapes, my sugars go up. But when I take mangoes, my sugar doesn't go up. So I say, how do you know? I say, I ate one mango and 2 hours later, I check my sugar is 150 and I had a handful of grapes and my blood sugar is 180. So in my body, the grapes produce more sugar. Same thing, many people tell us, doctor, what are you telling me about the rice? Even if I eat roti, my blood sugar after 1 hour and 2 hours is high. All these things have become a very common source of information when the people are monitoring their blood sugar frequently. So this monitoring blood sugar frequently is definitely tells you three things. One, what kind of food produces what level of blood sugar? Second, what kind of physical activity reduces your sugar? Some people say, sir, I don't go for walks, but I do all the household work. I iron my clothes and I don't use a lift and I walk 50 steps. And my blood sugar after that is less than 160. But if I go for a walk for about an hour or so, it decreases my blood sugar to only by 100 points. And certain days, my blood sugar comes down even if I walk for 15 minutes. Certain days, my blood sugar does not come down if I walk for 1 hour. So there's so much of information you get by simply monitoring your blood sugar. Now, obviously, monitoring your blood sugar so frequently is problematic. Fingers are all pierced multiple times, they become blunt. The blood does not come out because the skin has become fibrosed and it hurts you. People try to economize on the needles they prick and they use the same needle 8, 10, 15 days. Obviously, it becomes blunt and it makes a lot of effort. A lot of people, while blood drop not coming out, they squeeze the tip of the finger. That is wrong. If you squeeze the tip of the finger in order to get the blood drop, then it will get diluted with the interstitial fluid and it will not be whole blood. Second thing, the venous blood that you get in a laboratory and the finger prick that you see, there's a difference of 20 milligrams. If this is 180, this has to be 160 because by the time the RBCs travel from the tip of your finger to the elbow where the vein is punctured and blood is collected, the venous blood, while this is a capillary blood, means this is actually a continuation of artery and vein. Capillaries are a network of arteries and veins. So this is about 20 milligrams more and this is 20 milligrams less. This is very important, particularly. Second thing, many times the blood samples are collected and the veins are very bad. So a lot of technicians do tack, 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 tack like this. They do it. They put a tight tourniquet. When you put a tight tourniquet and try to take out the blood, the RBCs may get hemolyzed. And that interferes with monitoring potassium, not blood. But it is not a right thing to do. And therefore, you'll realize monitoring with the blood sugar, but it has to be properly, a technique has to be used properly, a sharp needle, and you should not keep a gap. The strip should not be outdated. They should be kept in a cool, dry place and not moist. So all this, instructions you follow, then it is accurate reading, which you can monitoring safely. Many times what happens, the patient is going to decide the dose of insulin. For example, we have told him that look here, if your pre-lunch blood sugar is more than 200, you take 15 units of short-acting insulin. But he says, I'm not too sure I'm going to take my proper lunch today. I may just have a piece of bread and maybe a bowl of soup. So I said, in that case, you make adjustment at whatever the blood sugar level you are at 150. Your usual dose is 20 units of short-acting insulin, but you're not going to eat the daily given lunch. You're going to reduce it by about 30-40% calories. Then you reduce the dose of insulin. Many times what happens? The person does not take proper meal because he got gastritis or because some other drugs or he's admitted in the hospital. Many times we give a injection dose after he eats. Now, for example, a person is on 20 units of short-acting insulin and he's going to eat only one-third of the food. Then we say, look here, don't take insulin before your lunch. Take it after your lunch, immediately after, and take a ultra short-acting insulin. So that acts immediately, like intravenous insulin. You idea of taking insulin subcutaneously half an hour before your meal, because in a normal non-diabetic person, the insulin production which occurs in the portal circulation. That means it reaches straight to liver once the food comes in duodenum, first part of duodenum. The beta cells produce insulin there, the insulin released in the portal circulation. While when you are injecting insulin before lunch, you are injecting insulin into systemic circulation. So from the systemic circulation, for it to reach liver, it takes about 20 minutes. So that is the rationale of injecting insulin 20 minutes prior to lunch. So by the time the food which is digested comes to liver for metabolism, the insulin should arrive at that time, not earlier or late. If it comes late, it will cause postprandial blood sugar rise. If it is early, he may develop 4 p.m. hypoglycemia, which is also dangerous. So these are all the techniques of monitoring which should be available to everybody. Now, all these strips and all these gadgets is an expensive affair. The gadget costs around 3,000-4,000 rupees. The strips are around 25 rupees per strip. You are doing monitoring 4 times a day, 100 rupees a day. The cost of insulin is about 100 rupees a day. And other medicine, 300 rupees a day, the of treatment to stay disease-free or morbidity-free for an average person is around 10 to 15,000 rupees a month. So that's quite a lot because the strip companies are not going to give discount. The insulin companies are not going to give discounts to patient because they also have to maintain their staff, expenditure, the cool chain, particularly insulin making companies, they have to maintain what is known as cool chain from the point of time which it arrives to the port till the time it is distributed to the chemist. It must maintain a temperature, and the cold chain is to be maintained in such a way that the temperature of insulin should be between 2 and 8 degrees, not more than that, and not frozen. So this needs a lot of expenses in travel, expenses in handling, bottling, distribution. So obviously the margin is there, not that the margin they don't have, but certain amount of expenditure bound to take place to have a pure insulin and not either contaminated or who's expired. The life of the insulin should be in the present gap what is prescribed. It should not use a expired batch. No use. It will not work. It's like water. So to do that, it is going to cost some amount of money. But in that, supposing you increase monitoring, you insist that you should monitor at least 3 times a day before 3 meals to know exactly what's the meal pattern and how much insulin to take. And to see their effect, maybe twice a week you do 5 times monitoring, becomes very tedious, cumbersome, painful. So people have come up with what is known as CGMS, That is known as continuous glucose monitoring system. It's a device which is put on your arm. This comes in a form of a disc, which has a sensor in it. That sensor is pierced under the skin and it tells you the sugar value of the underlying subcutaneous tissue, interstitial tissue. It doesn't tell you capillary or venous blood sugar. And when you check this, which is CGMS, there is a reader for that. You put that reader next to the reader, gives you a reading. Now this reading and the reading that you get from the venous sample, there could be a difference of 20 milligrams, not more than that. Means this interstitial blood sugar tends to be about 20 milligram more than the venous sample. But if this is more than 40, 50 and consistently variable, whatever is the difference between the venous sample or the CGMS sample should be steady. It should not keep on varying. It keeps on varying, then there's something wrong with the sensor and the company is kind enough to change it. These gadgets are available, very nice, they're expensive, but the reader is given, there are many schemes available, and this one sensor can be stuck on your hand and you can take bath, you can go for swimming with that. The well is stuck so well, it doesn't come out unless you bang it on the side of the door, then it may be, distorted. But the point is, it's very reliable. CGMS monitoring is done very frequently, particularly people who need to prick their fingers 5 to 6 times. And I use it very often, post-operatively, because we need to monitor blood sugar every hourly after CABG and after major surgeries that we do in hospitals. And it's fairly reliable. And it is less torturous and painful to patient. And the CGMS can come in a form of a graph. It can tell you what is the most important thing, more reliable than HbA1c is one concept known as time in the range. Now, what is the time in the range? You check the blood sugar, that computer keeps on recording it, and it tells you how many times in a day the blood sugar is lower than 140 milligram, which is a set target. And a blood sugar between 110 to 140, we have kept a target. And if the time in the range is 70 to 80%, then this diabetes control is excellent. But if you have got too many hypos and too much of hyper, if you have too many hypos and too much hyper, what will do? HbA1c will be normalized. But time in range will not tell you wrong things. It will tell you how many hypos, it will tell you how many hypers, and how many times the optimum blood sugar there in 24 hours of a patient, and how many 24 hours of 15 days, because this reading can go on for 15 days, will tell you time in range. So this time in range has acquired a lot of importance in the control of diabetes. And people who have a time in range about 80 to 80%, it is found that they are not developing microvascular complications to the extent that formerly type 2 diabetes used to get macrovascular complications. But now we see a lot of microvascular complications affecting kidneys in a type 2 diabetics. Type 2 diabetics with a high postprandial blood sugar, and particularly Asian phenotypes, they have a abdominal obesity, visceral fat. They tend to have a higher post-glycemic range. And that is largely because our diets are carbocentric. We eat a lot of carbohydrates during lunch. And this postprandial blood sugar is higher, which invites trouble to your coronary arteries. And there are many studies, they show that even twice or 3 times, if the blood sugar is more than 200, you are heading towards coronary vascular disease. And therefore, you have to bring down the postprandial blood sugars by either reducing your glucocentric diets or give you what is known as prandial regulators. Now, what is these prandial regulators? They are drugs which act as a meal time. And during the mealtime, they have a short span of action. Immediately after lunch, the blood sugar which spurts, or they call it glycemic variability, these prandial regulators will reduce this glycemic variability, GV, which is an equally bad factor in management of diabetes. So GV is reduced, PP sugar is reduced, and that's how the prandial regulators have come into action. Only problem with the short-acting insulin analogs, if you take a larger dose than the meal, then there is a chance of postprandial hypoglycemia. There is another danger thing that we call it, and that also can be controlled by optimizing your amount of insulin in a day. In order to control your diabetes, supposing if you are needing around 30 to 35 units of insulin, that's not bad because that's what the normal body produces. But if you need 100 units of insulin, it can do two things. Insulin in a larger dose can produce edema, particularly with the ankle edema. And second thing, there is something known as HbA1c Kg paradox. What is this HbA1c Kg paradox? As the HbA1c starts coming down, your body weight increases in kg. People put on, after insulin therapy in a month's time, about 5 to 6 kilos of weight. Most of the time, this weight is actually the weight that the patient has lost because of glycosuria. And because of glycosuria, there is a lot of water loss. That is regained first. Is the water retention. Because the glycosuria is prevented, the glucose is stopped coming out of urine, so the water loss is also prevented. In a chronic diabetes patient who has not been treated is a state of dehydration. So dehydration is corrected at the time the weight is corrected, but there is something known as diabetic sarcopenia. The muscle mass shrinks and the fat increases. This sarcopenia is also reversed. The muscles which were looking slender and thin, because the insulin, it goes all the way, the sugar is taken back to muscles and the muscles are built. At the same time, it goes to liver. There is a mild hepatomegaly, and if it is excess, it can produce fat. And that's how one has to be very careful, and that's why monitoring is the key role in over-insulinization, under-insulinization, and taking an optimum dose without any side effects. So now you realize, friends, it's so important to monitor blood sugar in a diabetic patient. Monitoring is as important as therapy, and therefore, whatever little I have tried to tell you in a short span of time, and I'm thankful to Client for giving me an opportunity to express my views on monitoring. Thank you very much.